This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from the journal Neurosurgical Review, published in 2026. It's a systematic review and meta-analysis by Arend and colleagues titled Safety Profile and Surgical Outcomes of the Endoscopic Transorbital Approach as a Skull-Based Surgical Corridor.
This is a timely topic, Alara. We've seen a real shift in the last decade toward minimally invasive techniques. While traditional transcranial approaches are effective, we're always looking to minimize retraction-related brain injury, extensive soft tissue dissection, and of course those suboptimal cosmetic outcomes that can really impact a patient's quality of life.
Exactly. And the endoscopic transorbital approach, or ETOA, has emerged as a versatile surgical modality to address those concerns. It's been gaining prominence as a valuable alternative for selected skull-based pathologies in the anterior and middle cranial fossa.
For our listeners who might be early in their training, the ETOA usually involves a superior eyelid crease incision. It provides a short, direct surgical corridor to regions like the sphenoid wing, the cavernous sinus, and even mesoscaphe. But the big question has always been, is it as safe as we think?
That's exactly what this study aimed to answer. The authors systematically searched PubMed, Embase, Scopus, and Web of Science up to March 2026. They specifically looked for studies with at least 5 patients where ETOA was used as the sole surgical modality. They ended up with 11 observational studies, totaling 269 patients.
269 patients is a solid number for a relatively new approach. What did the patient population look like in terms of pathology?
It was quite diverse. They reported on 21 different pathologies. However, meningiomas were by far the most frequent, representing 60.6% of cases. After that, we saw schwannomas at 12%, cavernous hemangiomas at 4.6%, and gliomas at 2.7%. The mean follow-up across these studies was about 27.6 months, so we have a decent window into the midterm outcomes.
Let's dive into the surgical specifics. The paper mentions the superior eyelid crease as the primary entry point. Did they discuss surgical freedom at all?
They did. The review highlights that the ETOA minimizes soft tissue manipulation. They also noted that quantitative anatomical studies show the extent of orbitotomy is crucial. Specifically, the removal of the lateral orbital rim significantly enhances surgical freedom, which is vital when you're working in tight corridors like the sphenoid wing or near the cavernous sinus.
That's a key technical pearl. Now, let's get to the meat of the meta-analysis, the safety profile. If I'm counseling a patient for a sphenoid wing meningioma via ETOA, what are the complication risks according to this data?
Let's start with the big neurosurgical complications. The rate of CSF leak was impressively low, at only 1%. Wound infections were also quite low, seen in only 3% of patients. Perhaps most importantly for the safety profile, the mortality rate across all 269 patients was 0%.
0% mortality is an excellent headline, and a 1% CSF leak rate is very competitive compared to traditional open or even some endonasal approaches. But we are working through the orbit here. What did the ocular and cranial nerve outcomes look like?
That's where the data gets more granular. Because we are traversing the orbital space, there are specific risks. The meta-analysis found that ptosis occurred in 4% of cases, and diplopia was reported in 6%. Medial gaze palsy was slightly higher, occurring in 9% of patients.
And what about the sensory nerves?
That was actually the most common transient finding. Transient facial numbness occurred in 16% of patients. It's important to emphasize that the authors categorize this as transient, likely due to manipulation of the branches of the trigeminal nerve during the approach.
That's a high enough number that we should definitely be including in our informed consent discussions. 16% is not insignificant, even if it is transient. Now, many of these patients, especially those with orbital or sphenoid lesions, already have visual deficits. Does the ETOA help them?
The results there are quite promising. Improvement in visual function was seen in 47% of patients. Conversely, new or worsening visual dysfunction was rare, occurring in only 1% of the cohort.
So nearly half the patients saw an improvement, and the risk of making their vision worse was only 1%. That's a very favorable risk-benefit ratio for a skull-based corridor.
It really is. The authors suggest that ETOA is a safe and promising technique for managing a wide range of skull base and orbital lesions. They highlight that it offers a direct route with minimal brain retraction, which is a major advantage over traditional transcranial routes.
One thing I noted in the paper was the heterogeneity in some of the results. Did the authors address that?
Yes, they were very transparent about it. They use the I-square statistic and Bowjat plots to explore heterogeneity. For example, ptosis and diplopia had higher heterogeneity, I-square of 79.4% and 68.9% respectively. This might be due to variations in surgical technique, such as the extent of the orbitotomy or the specific way the periorbita was handled across different centers.
That makes sense. Surgical nuance in the orbit can vary wildly between an orbital-trained neurosurgeon and someone who is just starting to adopt the technique. What about the learning curve? Did the study touch on that?
Indirectly, by including studies with at least 5 patients, they tried to look at established series, but they do emphasize the need for future prospective and comparative studies to really refine the indications and validate long-term efficacy.
It's also interesting to see the range of pathologies. While meningioma is the workhorse here, seeing 21 different pathologies, including schwannomas and gliomas, shows that surgeons are pushing the boundaries of this surgical corridor.
Definitely. The corridor provides access to the middle cranial fossa and Meckel's cave, which are traditionally quite difficult to reach with significant temporal lobe retraction. By coming under or through the orbit, you bypass that brain manipulation.
Let's recap those key statistics for our residents who are taking notes for their boards.
Sure. For the ETOA, meningiomas are the most common pathology at 60%, CSF leak rate 1%, wound infection 3%, visual improvement 47%, new visual dysfunction 1%, transient facial numbness 16%, mortality 0%.
And the cranionerve morbidity, ptosis at 4%, diplopia at 6%, and medial gaze palsy at 9%.
Correct. And remember that those ocular motor issues often have higher heterogeneity in the data, suggesting they may be technique dependent.
This paper really solidifies ETOA as a legitimate part of the modern neurosurgeon's armamentarium. It's no longer just a niche experimental approach. With 269 patients in these kinds of safety numbers, it's something we should be discussing more in our tumor boards.
I agree. The cosmetic benefit of the superior eyelid crease incision also can't be overstated. Patients are often very concerned about the visible markers of brain surgery, and this approach is nearly invisible once healed.
Well, this has been a great deep dive, Alara. The ETOA represents that perfect intersection of anatomy and technology. Before we wrap up, what's the final take-home from the authors?
The authors conclude that ETOA is a safe and promising technique. However, they call for more comparative studies. We need to see how ETOA stacks up head-to-head against the endoscopic endonasal approach or traditional craniotomies in a controlled way.
A perfect segue into our next episode. Thank you, Alara, and thank you to our listeners. This was a review of the 2026 meta-analysis on the endoscopic transorbital approach.
Thanks for having me. See you next time on the Neurosurgery Hub podcast.
Stay sharp. Over and out.